Ready, Thad? Okay. We're going to talk about newer cephalosporins today. And at the end, if you're going to fall asleep, wake up for about the last 5 slides. Okay, that'll summarize kind of what you need to know here. I have no disclosures at this time. We're going to talk about the cell wall today because we're talking about cephalosporins. You've heard me on round say that the bacterial cell wall is much like constructing a ladder. You cross-link the ladder, and what does that are the penicillin binding proteins, and that's the target for our penicillins and cephalosporins. So the inhibition of this cross-linking by the beta-lactam antibiotics compromises the structural integrity of the bacterial cell wall and leads to aberrant cell morphology, and that causes death. So I've got a Star Wars themes today. These are called the cell wall wars. I think we've talked about some of these antibiotics before on rounds. There's our buddy daptomycin that we've talked about. It causes membrane depolarization. Here's fosfomycin you'll see is used for UTIs. May not know that, but also interferes with cell wall. Here's the vancomycin we've talked about, the dealanine before. And here's the target for the penicillins. So we're talking about attacking the cell wall today. We attack their cell wall. They build it up. They build defenses for that. We're not doing so well over the last 10 years. You know, for a while, all we focused on was MRSA. The MRSA rates actually in all the hospitals, including the medical center, is actually down compared to 5 years ago. But what's rising are the gram-negatives. The Pseudomonas are making a comeback. Acinetobacter is greater than it ever was before. And E. coli and Klebsiella are a lot tougher than it ever was before. So when I sat in your chairs, Rocephin killed 99% of all E. coli and Klebsiella. So Klebsiella and E. coli were never a problem. So what's the differences between how a gram-positive does things and how a gram-negative does things? With a gram-positive, there's a large amount of beta-lactamase released outside the cell. So the battle occurs outside the cell. With gram-negatives, there's a porin channel that you have to go through that's not present with the gram-positive. This has been analogous to running a gauntlet. So you've got to run a gauntlet to get to your target site. And inside of these places, you can line up beta-lactamases. So if you're running down the hall to VA, you've got somebody with a bow and arrow in every room as you come by trying to pick you off at close range versus trying to shoot you in the parking lot. So you think about gram-positives, it's penicillin binding proteins. That's what does MRSA, right? When you think about gram-negatives, it's beta-lactamases. So how we get resistant between, say, MRSA and Pseudomonas are fundamentally different. So, what do we have to combat all these bad gram-negatives? I'm going to talk about 2 antibiotics today. So all you got to learn about is 2 antibiotics that are up and coming. These are FDA approved, but they're expensive and they're not on the Vitec machine, that little printout that does everything yet. So in the next year or so, you'll see more about this. So I'm just kind of giving you a heads up for what's coming. The first one is Ceftolozane. Brand names are Baxa, Ceftolozane. Ceftolozane is combined with an old friend that you know, tazobactam. Now, which drug has tazobactam in it? Zosyn. Use that every day at the VA, it looks like. So tazobactam. So we're taking a new drug, a new cephalosporin, and combining it with an old beta-lactamase inhibitor. Now, if you think about it, there's always been ampicillin-tazobactam, amoxicillin, clavulanic acid, piperacillin-tazobactam. To this drug, we have never combined a cephalosporin with a beta-lactamase inhibitor. So this is the first. So we're taking a new cephalosporin and an old beta-lactamase inhibitor and put them together. So what's it for? Ceftolozane, Pseudomonas. Some other things, but take one thing away, ceftolozane, tazobactam, your target, it was made for Pseudomonas. So the labeling, what could you now use it for? A urinary tract infection, obviously probably Pseudomonas, a bad Pseudomonas pyelonephritis that's resistant to everything else will be salvage therapy for this drug. Also intra-abdominal infections, so like a hospital patient who has a bad intra-abdominal infection afterwards, like so someone's in the hospital 10 days and then gets a diverticulitis or something, that would be another approved indication. Now, are cephalosporins good anaerobe drugs on the whole? They're terrible anaerobe drugs on the whole. So it's always been penicillin compared to cephalosporin. Anaerobes have always gone the advantage of the penicillin way. This drug's not much different. So we're having to add flagyl metronidazole to it. We'll come to that some later. What are we looking for in the future? We're looking at some phase 3 trials for these drugs. These are underway, and that's hospital-acquired pneumonia or ventilator-associated pneumonia, where you see Pseudomonas as much as ever. So for those of you seeing patients in a unit, we see these bad Pseudomonas on the ventilator and hospital-acquired. This drug's being, besides the UTIs we talked about, the intra-abdominal, really Pseudomonas isn't a big intra-abdominal bug, so mostly it'll be UTI and blood or someday ventilator-associated pneumonia. And these trials are going underway as we speak. So what makes ceftolozane different? It's an oxyminocephalosporin. So what's it look like? It doesn't look like Ancef. That would make sense. It wouldn't be a Pseudomonas drug, right? It looks more like our advanced generation cephalosporins like ceftriaxone and cefepime. We're going to change it around a little bit. You don't need to know all this, just pharmacy talk. It's got some different side chains, this 7-aminothiazole. What does all this matter? All those beta-lactamases I showed you when you run the gauntlet, these things better against beta-lactamases. If you're better against beta-lactamases, Pseudomonas is going to have a harder time with you. You've heard us talk about rounds about AMP-C resistance before. Certain bugs make AMP-Cs, originally derived from ampicillin. A bad beta-lactamase. AMP-C is a level above ESBL, but not quite the KPCs you hear us talk about. Pseudomonas makes a lot of AMP-Cs. We put a big bulky side chain on this antibiotic, and these AMP-Cs aren't near as effective as they used to be, so a better chance of getting Pseudomonas. Now, even though we're getting Pseudomonas better based on the ceftolozane part of it, ceftolozane still has some things that it can be weak against. It can still be picked off some. E. coli and Klebsiella can still try to go after this drug, even though it's going after Pseudomonas primarily. So you add tazobactam to it. When you add tazobactam to piperacillin, it increases the E. coli and its Klebsiella coverage. Tazobactam does not increase piperacillin Pseudomonas coverage, by the way. So because you may sometimes use this drug, let's say you got a diverticulitis with Pseudomonas and E. coli in there, or diabetic foot with E. coli and Pseudomonas someday, or get 2 to 3 bugs out of ventilator-associated pneumonia, you need this tazobactam to protect this drug against ESBLs, things we see all the time. And they work a little bit against anaerobes, but this isn't much of an anaerobe drug. Now, compared to its cousin, ceftazidime, it doesn't have as much resistance because it also binds those penicillin binding proteins a little bit tighter. It's mostly better because it doesn't get picked off of beta-lactamases, but it also grabs the penicillin binding proteins a little bit better. And also that AMP-C enzyme, it gets turned on. Certain antibiotics are what we call inducers. The bacteria see the antibiotic and they turn on the resistance mechanism. This one's less likely to turn on the AMP-C. So when you look at it, its big thing, as we said before, is it's potent against Pseudomonas. Now, is this a staph drug? We'll be using this? No, it's not a staph drug. It's not a MRSA drug at all. I mean, if you had a little bit of staph in there with your Pseudomonas, you're probably okay. Don't pull this out for staph aureus. It's not an intercoccal drug in no shape, form, or fashion. So here's a busy slide with a bunch of MICs, just to point out a few things. If you look at Bacteroides, well, that's not a good number when you see 8s for Bacteroides, so that's not really a great anaerobe drug. It's not too bad for E. coli, Klebsiella, but even though I told you it has some ESBL activity, it's not meropenem. This is not imipenem, ertapenem for E. coli and Klebsiella. It's better than ceftriaxone ever dreamed of being. So think of it being between ceftriaxone and imipenem for E. coli and Klebsiella. Think of it being superior to meropenem, imipenem for Pseudomonas. That's sort of what this slide will show. Not a staph drug, not really much of an anaerobe drug, although it has some. We don't trust it enough. We add flagyl to it. So here's some of the things we said before. Notice that if you're looking at ESBLs, it's okay for a while, much better than some of the other drugs that are in there. But look at it compared to meropenem. 0.12 compared to 4. So if you're just growing an ESBL in the next year or two and this drug's out there, choose a carbapenem. It's a better drug for an ESBL. It's a little bit E. coli and a lot of Pseudomonas, you may be okay. Notice the dreaded KPC, the Klebsiella that destroys carbapenems. The worst version of that came out of India with the metallo-beta-lactamase. You heard about in the news, the New Delhi strain. This is not good for KPC. We'll come to one of this. This is a Pseudomonas drug, not a KPC drug, not a MRSA drug, not an anaerobe drug. We'll come to one that's a better KPC later. So, if you compare all the nasty Pseudomonases out there when they were developing this drug, the only drug better than this for Pseudomonas is colistin. Now, you'll see us use colistin a little bit. How many of you guys have ever even written for colistin? Probably on ID, probably, half the time. Nasty drug. Pulled off the shelves because it's bad, but we had to have it. Colistin's major toxicities are what? Anybody remember that? Nephroneuro. Hurt your kidneys, kind of like aminoglycoside. And also may cause some peripheral neuropathy if you have long-term use. We aerosolize the drug to get into the lungs sometimes, a little controversial, mostly for cystic fibrosis. Anytime we aerosolize the drug, it's for two reasons. A, to get it to the target site, but B, to keep it away from everything else. So you aerosolize it to keep it away from the kidneys, okay? So this thing is ranking right up there with colistin. It'd be nice not to have to use colistin in some of these patients and units who have borderline kidney function. As we said before, its break points for like Enterobacteriaceae and anaerobes is maybe better than ceftazidime, but nowhere close to meropenem. It'll get some Bacteroides, but it misses so many other anaerobes that if you're looking at a diverticulitis and don't have cultures yet, you don't know if it's the Bacteroides that it gets versus the Bacteroides and anaerobes that it doesn't get. So in the clinical trials, we added flagyl to that. Back up a little bit and talk about what's different between a penicillin and cephalosporin. Often tell the medical students you have a house and a garage. With a cephalosporin, you have a basement. We added a 6-membered ring. Doesn't look like a whole lot. It's kind of flat looking on paper. If you put that in the three-dimensional world, it's a world of difference. That extra ring and all these side chains is what gives all the different antibiotics their different potencies. So this is a cephalosporin. As we said before, we've always added beta-lactamase inhibitors to these. We've never added it to that. You ever wonder why the penicillin works so well? Why do penicillins work? You've heard me talk about with vancomycin that vancomycin is going to bind the 2 dealanines, identical twins, I'll call it all rounds. Look how close the penicillin ring looks to 2 dealanines. When the penicillin binding protein comes up there, it's confused. Do I take the penicillin or do I take my substrate? It's a look-alike. So the reason that penicillins work is they look like the amino acid complex they're trying to bind. Just a little pictorial image. Ever wonder why beta-lactamases work so well? Looks a heck of a lot like a penicillin binding protein. Sometimes it's just good to see pictures to know, well, these little drugs you just write every day are actually real molecules and not just words on a piece of picture. That's why they work so well. Here's our old friend Ceftolozane-tazobactam, or our new friend Ceftolozane-tazobactam at the bottom. Now, does that not look a lot like a penicillin itself? Tazobactam. If I didn't put that word up there and I told you that was cefepime, would you know any different? That's why it works. It's a decoy. Matter of fact, the way they figured out to use sulbactam was not made as a beta-lactamase inhibitor. Sulbactam was made as an antibiotic. It failed so miserably, they said, oh, well, this is not going to work. Then somebody decided, oh, it failed so miserably because everything went after it. So if you put sulbactam with ampicillin, everything goes after the sulbactam. The beta-lactamases go after the sulbactam and leave the ampicillin alone. It's the ampicillin that does the killing. It's the piperacillin that does the killing. It's the ceftolozane that does the killing. Beta-lactamase inhibitors are just decoy molecules. Pretty darn good decoy molecules, but they're decoy molecules. So besides destroying the antibiotic or altering the target, so if I'm trying to get to my car right now, you can stop me from starting the engine in a couple different ways. Take my car keys and bend them right now. Somebody else goes and changes the lock on my door. Or as I try to get out, a couple big guys just push me back in. Efflux pumps are like the latter. I'm trying to get out the door and somebody pushes me back in. Or I'm trying to get into the bar and the bouncer at the bar won't let me in. Or you can have like a revolving door. So you keep trying to get out the door and it keeps revolving you around and putting you back in. So besides destroying the drug or changing the target, there's efflux pumps. Now generally efflux pumps are an additional mechanism resistance, not the major mechanism resistance. They're an add-on. So like the main thing you do is destroy my car key or change the lock on my door. One family of drugs, efflux pumps, are the major mechanism of resistance, and that would be tetracyclines. Tetracyclines, that's the major thing. So that's how you would destroy a drug. So trying to make this ceftolozane cover more bugs, we've added the tazobactam to it as a decoy drug. Now, what does it miss? As we said before, it gets some of the ESBLs, but not all the ESBLs. There's different families of ESBLs. So it'll miss 20% of them. It'll miss all the ones that destroy carbapenems, all the KPCs. So how does Pseudomonas become Pseudomonas? How does it become this terrible bug that's hard to kill so much? Different drugs have different things it does. See all those beta-lactamases at the top? Our new one, not so affected by all the historical beta-lactamases, except the dreaded KPC, which isn't so much in Pseudomonas right now, it's more in Klebsiella and E. coli. Cefepime and piperacillin are picked off by some of these. That's why, you know, Zosyn doesn't cover all the Pseudomonas anymore. How many times have you seen a Zosyn-resistant Pseudomonas? More and more frequent. At one point, it was 95 to 90% of all Pseudomonas. 80% in some places now. Even imipenem is picked off by some of the KPCs. Aminoglycosides are picked off by aminoglycoside modifying enzymes. Pseudomonas does lots of different things. If you're talking fluoroquinolones, it changes the DNA gyrase, right? This thing is more resistant to all of Pseudomonas' tricks. So when it comes to beta-lactamases, it's more potent against the beta-lactamases. It's not pumped out as much. It doesn't turn on the enzymes as much. That's what makes it a better Pseudomonas drug. Now, where are most cephalosporins cleared out of your body? You always look at your creatinine clearance, right? The exception being rocephin, right? So like all your other cephalosporins, check your creatinine clearance. It gets out through the kidney. And even some of it is removed by hemodialysis. So just like Maxipine, just like Fortaz, just like Ancef, cut it back with renal failure. Now, when we talk about beta-lactams, how do they kill? Are they concentration-dependent killers or are they time-dependent killers? They're time-dependent killers. A concentration-dependent killer to me is like an aminoglycoside. That's like a heavyweight boxer who's going to knock you down with one huge punch. That's why you can see me give Tober like 400 to 500 milligrams as a single dose. Whereas with beta-lactam, it's more like a little boxer that has to keep you on the ropes the whole fight. They have to stay on you all the time, or at least half the time. So what you can't do is like give one huge dose of 12 grams of Zosyn all at once and be done for the day. A, the kidneys will get rid of it, and two, the bacteria is going to escape that. So if your IV falls out in the middle of the night, aminoglycoside, not such a big deal. Beta-lactam, better get it back in. So what led to its approval? Well, they did some studies looking at complicated intra-abdominal infections and complicated UTIs, as we said before. They even looked at pyelonephritis. So they took ceftolozane and took it against a standard drug, ceftazidime, and basically it did just as well And if you had bad Pseudomonas, it did even better. So it's approved for like a bad pyelonephritis with any gram-negative rod almost, but particularly a Pseudomonas. Now once again, I said it's not a great anaerobe drug. It has a little bit, a lot more than ceftriaxone has, for example, a lot more than Ancef ever dreamed of having. But if you're going to use it for the belly, add Flagyl to it. So here it's up against a great belly drug, meropenem. So basically when you're looking at it versus meropenem, it's pretty much equal. There's really a non-inferiority against meropenem if you add the metronidazole to it. As you might expect, it has no activity against C. diff and in fact can cause C. diff, like most of our big guns. So they also compared it against a completely different family. So they compared it against Levaquin, often used for urinary tract infections. Most of these patients were known to have pyelonephritis. You might imagine it's better than Levaquin for UTI. Why? Because Levaquin has a lot of problems with gram-negative rods anymore, right? Sensitivity for Pseudomonas with Levaquin at the med center is about what? 50%. So if you're just using Levaquin empirically and think Pseudomonas is in play, you've missed it half the time. Previously 90%. One reason why we're looking for new drugs, the Levaquin doesn't do that well. If you look at the Levaquin resistant strains, it stomped it. If you look at those absolute differences there on the right, look how much better you did for Pseudomonas with an odds ratio. Well, it makes sense. The Levaquin missed it. So a much better drug than the fluoroquinolones for gram-negative rods. Once again, we talked about there's 2 large trials treated for intra-abdominal infection, and as you might imagine, versus meropenem, it was about the same outcome. We can spare the carbapenem some in the future with these drugs. We've used so many carbapenems, imipenem, meropenem over and over again. We're getting more resistance to them. It'd be nice to have a drug to spare these with. So if you look at the different bugs on the right, there's not a whole lot of difference between that and meropenem. So that's good. You got a drug that's just as good as meropenem for intra-abdominal infection. Wouldn't necessarily have to use the meropenem. Now, not made for meningitis. Not studied for meningitis, not made for meningitis. I bring it up because meropenem is made for meningitis. Where I think it may have a greater role in the future is ventilator-associated pneumonia. Our data won't be back, unfortunately, to around February of 2018. What's it like? Does it have any terrible side effects compared to the others? We know we've been using tazobactam for years, right? It's pretty much similar to any other cephalosporin. There's no unique toxicity of this drug compared to all your other beta-lactams. So, safe as Zosyn, safe as Fortaz, safe as Rocephin. So how do you dose it? 1.5 grams every 8 hours, and you adjust it for creatinine clearance. So pharmacy can help you with that, or we can help you with that. You cut it back. This is just for informational purposes. You cut the dose back if you've got a lower creatinine clearance of 30 to 50. So where do we think this will play in the world? I think that it'll be primarily a Pseudomonas drug. It's not any good against those metallo-beta-lactamases, as we said, but being good just for Pseudomonas is going to be an important drug to have in the future as we get more and more drugs picked off. Part of our trouble now, whenever they come out with a new drug, they price it through the roof. And whenever you come out with a new drug, they don't have it on the VITEC yet. Within a year or so, it'll probably be on the VITEC panel at the medical center. So let's switch drugs. We'll just recap Ceftolozane-tazobactam, Pseudomonas. We're switching guns. We've got another tool here. So another drug. Now what is this? This is an old drug with a new beta-lactamase inhibitor. Before, we had a new antibiotic with an old beta-lactamase inhibitor. So this time we're switching. We got an old drug with a new beta-lactamase inhibitor. So once again, there's another cephalosporin that has a beta-lactamase inhibitor added to it. So what are we after here? We're not after Pseudomonas. Does it get some Pseudomonas? Of course. It's got ceftazidime in it. Is that what avibactam's for? No. Avibactam is for Klebsiella and E. coli, particularly those that pick off carbapenems. It's for ESBLs. It's for AMP-Cs. It's even got some activity against the dreaded KPC, which no carbapenem is any good at all. Now let me just give you an aside now. There's a new machine at the medical center. When you draw a blood culture, it goes on this big old black box downstairs called the BAC-T. It rocks back and forth. It's as huge as an elevator. It's designed to pick up a bacteria in your blood in 8 hours after you draw the blood culture. And then at 8 hours, they do a gram stain, put it on a plate, put it in the Vitek like we've always done. They also have this new machine called a biofire. A biofire is a multiplex PCR that tests 22 different organisms. So 8 hours after you draw your blood culture, it may say, Thad, you have MRSA in the blood, 8 hours after you draw it. Or you have Klebsiella in the blood. You have Pseudomonas in the blood. You have now a KPC in your blood 8 hours. It'll tell you you've got a KPC in your blood 8 hours later. It'll tell you you've got a VRE in your blood 8 hours later. So if you get a call from the lab and you've got a KPC in your blood 8 hours later, your vancomycin is not going to cut it. Or if they tell you just got MSSA in your blood 8 hours later, why do you need to salt the patient with vancomycin? So we're going to get quicker ways of knowing which bacteria to be after. Same technology, by the way, will run 12 different bugs on your spinal fluid. We'll run 22 different specimens on your stool. We already probably have seen this order that RVP panel at the medical center that tests like 12 different viruses. They're going to be quicker molecular diagnostics to know what to go after first, which will help with antibiotic stewardship. So what does this avibactam do? It helps the ceftazidime pick up other bugs it didn't pick up before, primarily E. coli, Klebsiella. Now once again, we're after UTIs and intra-abdominal. So you're going after an old friend, Primaxin again. So if you're looking just at UTIs, we're taking on the carbapenem again. And if we're going after intra-abdominal, we're taking on another carbapenem, just happens to be meropenem again. So we're going after two of the biggest guns out there, imipenem and meropenem, and let's see how we do. So the FDA looks at this and said, well, if you're looking at a UTI, you got a pyelonephritis, or you're looking at a belly, you add it with metronidazole, based on these studies we'll go through, they decided to give approval for this is called AVCAS, by the way. You have approval now for a complicated UTI or an intra-abdominal, growing a nasty E. coli or Klebsiella. So it's 2 grams of that over an infusion every 8 hours. They're going to look at more UTIs and more intra-abdominal, trying to take the worst bugs they can find, trying to take the KPCs, trying to take as many ESBLs as they can find. And once again, like our other study, they're going to be looking at ventilator-associated pneumonias with ESBLs and Klebsiellas. So you make a bunch of cephalosporinases that destroys what we've had before. Ceftriaxone, shot. Cefepime, half shot. Fortaz, shot. We've shown that we can do better against Pseudomonas, but we're having trouble when we have meropenem and imipenem-resistant bugs, these carbapenemases. So when Rocephin covered everything, well, let me back up. At one point, believe it or not, ampicillin killed all the E. coli and Klebsiella we ever encountered. Ampicillin. And then ampicillin started having some trouble because a little thing called TEM came by. A little beta-lactamase came by and destroyed the ampicillin. TM named after a little girl named Tamora, by the way. Everybody hoped that was all there was to it. We come out with Rocephin. We killed 99% of them. End of story. Nobody worries about E. coli, Klebsiella. And then we started getting better beta-lactamases. That first beta-lactamase decided to mutate some. When it mutated, it has a bunch of different numbers now, TM32 or whatever. They destroyed the ceftriaxone that we depended on for years at 99%. It destroyed Zosyn, unheard of, that Klebsiella E. coli would destroy Zosyn. Started destroying those. Therefore, they extended its spectrum to the big guns. That's what the ESBL means. ESBL means, essentially, it picked off ceftriaxone and Zosyn. So what did we do? We went to the carbapenems. The carbapenems, 99% on those. End of story. We think we're done. Then we start seeing Klebsiellas and E. coli that destroy the carbapenems, so-called KPCs. We need a better drug for that. You can do colistin, nasty drug. You can do Tige sometimes, terrible for the lung, terrible for the blood, terrible for the urine. So we needed something better. So they come up with AVCAS, trying to treat this. Here's our old friend Ceftazidime. To make a long story short, way back in the day, you had stuff that made it good against E. coli, and way back in the day, you had stuff to make it good against Pseudomonas. But all these better beta-lactamases destroyed it, right? Adios ceftriaxone, adios ceftazidime. We need something new. We need a new approach, something we've not seen before. We need a novel inhibitor, okay? That one is avibactam. We need something new. Doesn't look much like that tazobactam, does it? Nah, they kind of look alike because they're all ring structures, but in fact there's quite a bit of difference between avibactam and every other beta-lactamase inhibitor we've ever made. You don't need to know all this. Just listen and let it go out of your head. It has a bicyclic core, which is completely different than the tazobactam. It has a different way that it resists beta-lactamases. It's not a very big molecule. That's nice when you're putting them together. So most beta-lactamase inhibitors, they either have a suicide pact where they go in there and destroy it, or they have some sort of transient occupancy and stuff. This one, you don't need to memorize this. All the little pharmacists out there like Justin and Paul will be ecstatic to know that it forms a carbamate linkage. What's that mean? Bottom line is that once it has a 7-minute recovery time versus 7 days. Whenever you have one of those others, tazobactam, if it's not working, it's like dead for 7 days before it reconfigures itself. This thing, when it gets whacked, it can reconfigure itself in 7 minutes. Bottom line is, it's a better beta-lactamase inhibitor. It's a whole lot better beta-lactamase inhibitor. So what does this whole lot better beta-lactamase inhibitor allows us to do? Is allows us to go after KPCs. KPCs have a hard time with this. And now, as I told you before, if you know in the blood that you got a KPC in the blood 8 hours after you draw it, you're on to this drug or you're on to colistin or something 7 hours, 8 hours later. Now, does it get all the carbapentamases in the world? No. It gets the easiest of the carbapentamases. The so-called New Delhi strain, the metallic forms, the zinc forms, it doesn't touch those. We're still suffering for a good drug besides colistin for that. If you look at it, though, it gets nearly all the E. coli and Klebsiella in the U.S. when it was tested, nearly every one of them, back to 99% again. And that includes all the meropenem-resistant strains. So once again, first drug, ceftolozane, Pseudomonas. This drug, Ceftazidime-avibactam, E. coli, Klebsiella. Now, does it have some Pseudomonas and Acinetobacter activity? Yeah, it's got some. It's got ceftazidime in there, right? But is it the equivalent of the other drug I showed you? No. It's not near as good as Pseudomonas. Now, if you got a nasty ESBL, Klebsiella in there, and say a definite KPC in there, and there's a little Pseudomonas running with it, you're probably okay. But if you're just growing Pseudomonas, this isn't your drug. If you're looking at these at the bottom, though, if you're looking at E. coli's that make AMP ESBLs and KPCs, this is your drug. That and colistin, maybe Tige sometimes. So we're getting new weapons. Very expensive weapons right now that I hope the cost will come down. They're anywhere from like $200 to $800 a day right now. Way overpriced. I'm hoping some of that will come down. Once again, remember we said before that the other drugs were not anaerobe drugs? These are not anaerobe drugs. These are probably even worse than the other ones are. These are not made for staph. These are not made for pneumococcus. These are not made for anaerobes. They get some beta hemolytic strep, group A strep if it happened to be there. These are made for gram-negatives. Their activity against anaerobes and staph. These are not your drugs. Once again, remember we said that most cephalosporins will go through your kidney. We knew ceftazidime went through your kidney, right? We knew that. Avibactam does the same thing. If you got some liver impairment, you don't have to worry about it. Avibactam doesn't care if you got a half-dead liver like a cirrhosis. Here's your dose that you're adjusting for creatinine clearances. As I said before, this is just for informational purposes. What are we looking at in the future for this drug? More studies for more complicated UTIs with the worst of the worst, as I said. More intra-abdominal infections with nasty E. coli's. And we're looking at ventilator-associated pneumonia. They had a few of these nasty KPCs in their original data. They're looking for more. We really want to know, with lots of patients around the world, what does it really do for drugs that reliably destroy imipenem and meropenem. So where would its place be? First drug, Pseudomonas drug. This one, bad E. coli, bad ESBL. Hopefully the KPCs. Right now, though, the bad New Delhi strain isn't our drug. The really bad carbapenemase isn't our drug. But in the U.S., for the most part, all you see are KPCs so far, but could be heading our way. So right now, approved for pyelonephritis, complicated intra-abdominal patients with flagell, if you had like a bad E. coli. Hard to say that'd be cost-effective compared to meropenem unless it's KPC. Once again, big target area, ventilator-associated pneumonia, trials underway. CRE is like the number one bug, the carbapenem-resistant Enterobacteriaceae, which is E. coli and Klebsiella. That's like the number one target for the CDC right now for new drug development. There's a little bit of effort. This one seems to be doing a little bit better for the KPCs, but we're still desperately lacking any new drugs for these bad bugs. This is like the first of several, hopefully, to come. So let's back up and talk about which antibiotics cover what for cephalosporins. So for Rocephin, what are we looking at using Rocephin for? Ceftriaxone. Great strep pneumo drug, right? Great strep pneumo drug for pneumonia, great for meningitis. Garden variety E. coli and Klebsiella. Not going to pick up any SBLs, not going to pick up any KPCs at all, right? That's what ceftriaxone is good for. Cefepime. What about cefepime? Maxipime, as some of us say. Pseudomonas, we kind of replaced ceftazidime for Pseudomonas. Has a little bit of activity against some of the AMP-C E. coli. It's better than ceftriaxone. Not a great ESBL drug, not an anaerobe drug, not a MRSA drug at all, right? How about ceftaroline? MRSA. Brand name Teflaro. It's a MRSA drug. I call it renal Rocephin with MRSA coverage. That's pretty much what it is. It covers E. coli and Klebsiella no better than Rocephin, though. So if you're talking a bad ESBL, one of these nasty ones, no. It was made for MRSA. If you happen to have MRSA in a foot and you got some garden variety E. coli in there, you're fine. Looking at bacteremia, they're studying for MRSA bacteremia and ventilator-associated pneumonias with MRSA. Right now, it's not technically approved for MRSA bacteremia unless it's transient with a skin soft tissue. They're looking at it for like endocarditis and pneumonia. Right now, it's more skin soft tissue pneumonia or skin soft tissue MRSA. Now, why I say renal Rocephin, as I said before, Rocephin doesn't need any adjustment with dead kidneys, right? The liver picks it up or the kidney picks it up if neither one of them is working. You have to adjust the Teflaro for the kidneys. So that's why I call it renal. Is it an intercoccal drug? Not by itself. Are any cephalosporins intercoccal drugs? Not as monotherapy at all. The only time you'll see me do that is what circumstance? Endocarditis. Now, brand new in the latest cardiac IDSA guidelines is an update on treating intercoccal endocarditis. And it turns out that we've always used like AMP and Gent all these years, right? Or Vanc and Gent. Well, what's the problem with that? 6 weeks of gentamicin. Not easy to give 6 weeks of gentamicin to anybody. Or Tober as far as that goes, but definitely 6. So we need a backup plan for that. And the backup plan is ampicillin still, but with ceftriaxone. Ceftriaxone at a dose of what? 2 grams Q12. Your endocarditis dose of ceftriaxone when you use it with ampicillin is the same as your meningitis dose. So your endocarditis ceftriaxone for enterococcus is 2Q12. So why does that work? Why does ceftriaxone don't do a thing on its own but works with ampicillin? It's because it doesn't bind the penicillin binding protein of enterococcus very well. So it binds it like this instead of like that. If it binds it like this and ampicillin binds it like that, you have a synergistic attack on different penicillin binding proteins. So with another better penicillin binding protein, you get extra kill. If you get extra kill, you can maybe avoid aminoglycoside. Now, if you get a rash, you get one heck of a beta-lactam rash. Kind of hard to sort that out if you started both on day one. To some degree, I tend to start with aminoglycoside for a couple of days and see if I can clear that bacteremia. You don't have to worry about what caused the rash on day one. But it's a safer drug for the next 6 weeks or so. The MRSA drug I told you about, the Teflaro, the ceftaroline, it may be used in the future like ceftriaxone with Enterococcus. So you may see us write ampicillin Teflaro in the future, because it may actually bind that penicillin binding protein of Enterococcus slightly better than Rocephin. Right now it's way more expensive. So the Zerbaxa we talked about, the Ceftolozane-tazobactam, what's it for? Pseudomonas. Ceftolozane, Pseudomonas. The next one is Ceftazidime-avibactam, the avibactam ceftazidime. What bugs for that? E. coli, Klebsiella. So those are your cephalosporins. None of those are great anaerobe drugs. Add Flagyl to any of those, or Clinda under some circumstances. Only one or two have any enterococcal coverage at all. None of those are C. diff drugs, and in fact they cause a lot of C. diff. So that's cephalosporins in a nutshell. You'll see more of these in the next year or two. Price come down a little bit. We're desperately lacking drugs for gram-negatives. There's tons of drugs for MRSA when you think about it. There's tons of drugs for MRSA. Daptos, Ivox, now cephalosporin, Vanco, Doxy, Bactrim, even Clinda. We've been lagging behind on gram-negatives. Across the country, gram-negatives are making a comeback from nosocomial infections. But the number one nosocomial infection nowadays is what? C. diff. C. diff across the country is now, may show up on little boards because they love epidemiology sometimes. The number one is now C. diff, passing MRSA. By far, passing MRSA a lot of times. So C. diff is now your number one nosocomial infection. I'll take any questions for you here. Any questions about that? Okay, thanks a lot.